Good morning, everyone. I, Dr. Shalini, on behalf of the National Board of Examinations, welcome all of you to this live and interactive teleconferencing session organized and presented by the National Board of Examinations in collaboration with IGNOU School of Health Sciences. Before we start, I would like to tell all of you about today's schedule. Today we have recent advances in medicine from 11 to 11:45 am. Next session would be about recent advances in surgery from 12 to 12:45 am. Then we would be having recent advances in pediatrics from 1 to 1:45 am, followed by recent advances in orthopedics from 2:30 to 3:15 am, and to conclude we would be having recent advances in ENT from 3:30 to 4:30 pm. At the onset, I would like to introduce to all of you Dr. Naresh Gupta, sitting on my immediate left. He is Professor of Medicine, Maulana Azad Medical College, New Delhi. To my right is Dr. Parag Kalra. He is working as Assistant Medical Executive in the Board of Examination. May I now request Dr. Naresh Gupta to begin with the session? Sir.
Thank you, Dr. Shalini, and a very good morning to all the listeners. In these next 40 minutes, I'll try to cover some of the recent advances that are relevant to those who are practicing medicine, especially the internal medicine. The first one relates to a different form of treating cancers, which relates to angiogenesis, and these are the angiogenesis inhibitors. Traditionally, we have treated cancers with those drugs that kill the cancer cells. But all cancers, whether they are solid tumors or metastatic tumors or leukemias, they need some kind of angiogenesis, blood microvessels, to keep growing, and each of those vessels supplies thousands of those cancer cells. Plus, there is no problem of any resistance developing with these angiogenesis inhibitors. So if we can manage this angiogenesis, if we can treat this angiogenesis process of cancer, we are likely to achieve a more sustained and a much wider benefit. This kind of a process was not available until some time back, but now there are about 3 dozen drugs that are in the pipeline which can be used for treating cancers and which have a anti-angiogenesis effect. They are all available some of them are available in the market also. The angiogenesis inhibitors can have the inhibition of new vessel formation primarily as their effect, as can occur with bevacizumab, which is available as Avastin, or as angiostatin or endostatin, and many others. Some of them have got inhibition of angiogenesis as their secondary effect. It could be something as simple as celecoxib or thalidomide or Taxol or rosiglitazone. They have their own implications, probably on a larger scale. Avastin has been approved for treatment of colorectal cancer, the metastatic colorectal cancer, and is available even in India. It is also effective in the treatment of lung, renal, ovarian and breast malignancies, and in January the gastroenterology group have found great benefit of this drug in treatment of pancreatic cancers also. Do I go to the next one or I wait? The next is regarding the emerging infections, and this relates to emerging invasive fungal infections. We know that the spectrum of infections is changing over the period of past few decades, and it could be because of increasing age, which is a immunosuppressant by itself, or the use of large number of antibiotics, immunosuppressives, anti-cancer drugs, solid organ transplantations, hematopoietic stem cell transplantations, HIV, AIDS, and many major surgeries which have come in. All of them predispose them to infections. But what we are finding, that the pattern of microbes that used to cause these infections is changing over the past 2 or 3 decades. The bacteria, we are very well aware that the gram-positive bacteria are coming back. We are also finding that there is a change in the pattern and spectrum of invasive fungal infections in these scenarios. Whereas 2 decades earlier, the invasive fungal infections would be Candida albicans and the like. Now we find it is the molds like the Fusarium, zygomycosis and other black molds which are more often responsible for fungal infections in the setting of immunocompromised state. Candida, even when it occurs, is more like a non-albicans Candida, and so also for the Aspergillus. Clinically, these new molds that cause infections can either cause a superficial infection or a locally invasive infection as in the sinuses and the lungs, or they can lead to a disseminated infection with fungemia. Very often the Fusarium species, zygomycosis and the likes cause sinopulmonary or pure pulmonary or the cerebral infection apart from involving the skin, eye, brain or the gastrointestinal tract and sometimes even the CVS. Fusarium is one of them and is found widely in the soil and water all around us. In fact, it is something that can come through the tap water also, the usual municipal corporation supply. One does not get affected by it unless one comes under a immunocompromised state. And the recent studies on fusariosis, the infections caused by the different species of Fusarium, show that 80% of them occur in association with one cancer or the other. The bad thing about this infection is that they don't respond so well to the conventional treatment and hence carry a poor prognosis. It was also implied that it may be better to prevent these infections which come from the natural soil and normal water sources rather than from any of the hospital settings. The fungus makes its way through the upper respiratory airways and reaches the different parts of the body and causes infections. The most common ones are the keratitis and onychomycosis, but apart from this it can cause involvement of the lungs, the sinuses, the kidneys and a disseminated infection. At this juncture, it may also be good to keep in mind that there has been a great advance made in newer antifungals and some of them are effective for treating these mold infections including the fusariosis infections. Traditionally, lipophilic amphotericin B has been used, but now we find benefit with voriconazole and posaconazole also in the treatment of these infections.
So kindly repeat the names of the antifungals, so the newer antifungals.
Apart from the lipid formulations of amphotericin B, there is voriconazole and posaconazole. Both are available now in the market, and they are the ones which work by affecting the lipid membrane of the fungus. They are the enzymes which are akin to the cytochrome enzymes of the human body, and they are found very effective in a large number of fungal infections, and they have a benefit against molds including the Fusarium, voriconazole and posaconazole. The next advance I am referring to is something that is being talked about even in the normal media, and it relates to the stem cell transplantation. For the transplantation of stem cell, which started from the field of hematology and hence referred to the hematopoietic stem cell, the sources traditionally have been the bone marrow. Apart from bone marrow, it can also be recovered from the peripheral blood. Both of them can be done either on a autologous basis or a allologous basis. Umbilical cord blood has come in to vogue in for the past 10 to 15 years, and during which time more than 6,000 transplants have been done using the stem cells derived from umbilical cord. Normally, the blood which contains these stem cells from the umbilical cord is discarded, and it is kind of not used anywhere. But it is a rich source of hematopoietic stem cells, and hence for the past decade or two it is being used more and more often for transplanting stem cells, which is the equivalent of the earlier bone marrow transplant. The advantage is one does not need to match it as one does for the bone marrow. It's a easy source, it is a cheap source. The results of using stem cell transplantation using the umbilical cord blood are as good as that of allogenic bone marrow transplantation in the children group of population, but they are not as good when it comes to the adult patients. Probably it has something to do with the dose of umbilical cord blood stem cell number that is available. For the pediatric patients, it may be still sufficient, whereas for adults, one will need to increase that number to the requisite level for that particular body weight. From the umbilical cord blood, you cannot use the same umbilical cord blood again for augmenting the supply of stem cells, but there are ways of expanding the yield from a given cord blood. It can either be pooled or sequential transplantation using the cord blood stem cells, or it can be expansion of the stem cells from the cord blood by using the growth factors, colony growth factors, stem cell growth factors, or the megakaryocytic growth factors. They can increase the number of stem cells that are available for transplant. Some of the workers in Europe have combined stem cell transplantation using the cord blood with haploidentical bone marrow transplant to augment the number of stem cells available for transplant. Another indirect approach has been to use non-myeloablative stem cell transplant, which implies that one uses a low level of immunosuppression when you are giving these transplants, and hence the damage is not so much. This has to be used in conjunction with the other three modalities. The next one relates to something which is often used, and that is the neuroimaging for coronary artery disease. We all know the use of CT angio or CT coronary angio that is being practiced widely. But when we look at the neuroimaging techniques, we find that the intravascular ultrasound is a good technique for early and preclinical detection of atheromatous plaques in suspected coronary artery disease cases. It's a very good technique, except that this becomes an invasive procedure because it has to be an intravascular ultrasound, and hence very often it is done as a part of the coronary angiography technique, so that you can supplement the coronary angiography with this and derive some conclusions, but it is a good technique. More often we find that CT coronary angiogram is used using a multiple slice, a multi-detector CT, and this has been accepted as a practice for non-CAD cases, which means if we have two group of patients where one suspects CAD and in one where you don't really suspect CAD, in the non-CAD group it has been found to have a good sensitivity, good specificity, and a good predictive value, each one being more than 90%, and hence it can be used to rule out a significant coronary artery disease in these cases. The presence of calcium in the coronary arteries interferes with this technique. However, the more resolution techniques like the 64 slice CT takes care of this problem. Another problem that comes with CT angio is the radiation dose that patient or the individual gets. The dose in one CT angio is twice that of a conventional angiography. Some studies have been done to find out whether CT angiography can also be of benefit in patients who are suspected to be having CAD. American Journal of Rheumatology last year reported some of these findings, where they had taken the patients with chest pain with ischemic heart disease, coronary artery disease was suspected, and patient underwent a CT coronary angio along with the conventional coronary angio within a span of 4 days. They found it had a good sensitivity, specificity, negative predictive value, and accuracy, but the positive predictive value was 52%. One probably will need to do more studies to find out the role and benefit of CT coronary angiography in cases of suspected CAD. Another technique that is being refined is the use of MRI for the detection and characterization of atheromatous plaques in patients with ischemic heart disease. This I have just talked about. It just lists whatever we said about the CT angio in detail, which is really picking up and is still used and is found in this last year's study. It was found good for the left main and the left anterior descending artery. Another advance which physicians, internists and everybody should know about is the human papilloma virus vaccine, which has been approved last year. It is available under the name of Gardasil. This probably is the first vaccine which is available to prevent a cancer, and a cancer which is a common cancer, the cervical cancer in women, which kills about 240,000 women in the developing world alone. It's an expensive vaccine, so it is not being marketed here as yet. It is being marketed in US, and they want to make it available to every young woman. The Europeans have started approving this market for use in their own countries. It is a quadrivalent vaccine which looks after 4 serotypes of human papilloma virus. 2 genotypes are HPV 16 and 18. These are the 2 genotypes that are responsible for 70% of the cervical cancers. Another 2 genotypes of HPV 6 and 11 are associated with the causation of genital warts. Both these things are prevented with the use of this vaccine. There are 3 shots that are required to be given over a period of 6 months, and they need to be given before the sexual activity starts. In the US, where this has been accepted, the age given is 9 to 26 years, but it can vary from place to place. Since it's a absolutely new vaccine, we still do not know whether there would be a need for a booster vaccine at a later date or not, but a 75% of the sexually active persons are likely to catch human papilloma virus sometime or the other during their lifetime, implying that this vaccine can really become a great boon for the humanity in times to come. We all know about the probiotics, and they are being promoted widely with some benefit, small benefit, but there is a concept of recombinant probiotics that has come in, reported in gastroenterology last year, and what was done was a very ingenious thing. This was the use of recombinant probiotics to prevent the spread of cholera infection. Vibrio cholerae, when it gets into the intestine, it has to bind to a receptor which is a ganglioside M1 receptor. What is done is these harmless Escherichia coli bacteria are modified by transferring the genes from Neisseria meningitidis and Campylobacter jejuni, which transfers a glycosyl transferase and leads to the formation of a lipopolysaccharide which mimics the ganglioside M1 receptor. When the Vibrio cholerae gets in, this particular modified lipopolysaccharide akin to GM binds the cholera toxin, and once it binds the cholera toxin, it takes away the effect of the toxin from the human body. The binding of the cholera toxin to this modified lipopolysaccharide is very strong. The affinity is very strong, and it can bind 5 times its own weight of the cholera toxin. Now this was done, and then it was tried in mice. The studies were done in mice. Human studies are not there, and the mice model showed that 12 out of 12 mice who had been exposed to cholera, and 1 hour later this particular recombinant probiotics was given, 12 out of 12 mice survived, whereas in the control group only 1 out of 12 survived. So it has a great potential, and such kind of recombinant probiotics are also being used for managing other infections and using other bacteria. Another advance has been made in the concept of enzyme replacement therapy. Enzyme therapy or enzyme replacement therapy is used by all systems of medicine and is more often practiced by non-allopathic systems of medicine. But when we talk about replacement therapy, we talk about replacement of an enzyme in a disease or a situation where that enzyme is either deficient or is absent. We know about the gastrointestinal enzymes, but ERT has become a great boon for lysosomal storage diseases, wherein there is a deficiency of enzyme which leads to the accumulation of substrate, and this accumulated substrate, which varies from disease to disease, gets into the macrophage monocyte system and leads to expansion of the macrophage monocyte system. Some of these things lead to the formation of toxic products which can be damaging to the brain, to the heart, to the kidney, to the muscle, and many other things. The enzymes were developed and they have to be given by the intravenous route, and some of them are well established. Like for Gaucher's disease, where there is accumulation of glucocerebrosides in the macrophage monocyte system, these get accumulated in the lysosomes. That's why these diseases are called the lysosomal storage diseases. The replacement enzyme is imiglucoserase, that is available as Serizyme in the market. Similarly, for Fabry's disease, Fabryzyme and Eldorazyme are available. They may be expensive, but if they are given early, they are beneficial to these patients. They have to be given early because this enzyme replacement therapy is kind of a symptomatic therapy which prevents further damage. It does not cure the disease, and it does not look after all the aspects of the disease. So if one is using it in Gaucher's disease, one might like to use it in type 1, which is a non-neuropathic variant, and the benefits would be sustained so long as one keeps using these enzymes. What has been happening in the last couple of years is the expansion of this enzyme replacement therapy. Last year, Myozyme, which is a glucosidase enzyme, is required in the